Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Muhamad Aly Rifai, psychiatrist, internist, and addiction medicine specialist. Today's Kevin MD article is The Crisis in Inpatient Psychiatric Care. Muhammad, welcome back to the show.
Thank you very much for having me to talk about the current issue about the crisis in inpatient psychiatric care here in the United States and propose some solutions for streamlining inpatient psychiatric care and talk about my experience as an inpatient psychiatric provider for many years.
All right, so tell us about this crisis.
So, in the United States, as well as around the world, individuals who experience psychiatric emergencies, individuals who experience severe depression and suicidal ideation, thoughts about ending their lives, thoughts about not wanting to be around, as well as individuals who experience severe psychiatric emergencies that they become a danger to others, end up being hospitalized psychiatrically. And usually these emergencies happen when either the individual comes voluntarily to a hospital emergency room for psychiatric admission, or families notice the psychiatric and acute need of their loved one, whether them becoming suicidal and verbalizing that they're wanting to end their life, or whether they becoming dangerous to others. Sometimes even these individuals come to the attention of authorities, police, ambulances, fire departments that end up bringing them to the hospital for inpatient psychiatric admissions. Around the country here in the United States, the regulations and the laws about inpatient psychiatric admissions vary from state to state. But the majority of states mandate an inpatient psychiatric admission if somebody is exhibiting tendencies to harm themselves or harm others, as well as being unable to care for themselves. And we have a patchwork of laws, state laws around the country that mandates also involuntary psychiatric hospitalization if somebody is unable to care for themselves, or if somebody is exhibiting thoughts about suicide, thoughts about harming somebody else, where an individual is hospitalized involuntarily to an inpatient psychiatric hospitalization. We have seen over the last 30 years that there have been actually a significant decrease in our capacity in terms of inpatient psychiatric beds. Patients were being hospitalized less and less. This actually movement started even 60 years ago, where the state hospital systems was basically dismantled. We rarely now have state psychiatric hospitals in different states. And we were seeing that this tendency of hospitalizing individuals actually has kind of gone by the wayside. Individuals are managed on an outpatient basis, but still some people will require inpatient psychiatric care. And we have seen trends where that has decreased, and we're seeing a lot of pressures in terms of whether to hospitalize somebody or not to hospitalize somebody. And me, as an inpatient psychiatric provider for many years, I wrote about these pressures. These are societal pressures, these are insurance pressures, these are government pressures. And we, as physicians who manage inpatient psychiatric services, are between a rock and a hard place with managing these competing needs for patients, insurers, government regulators, society, and that is an untenable situation for us.
So you mentioned that you yourself, of course, is caught in the situation as an inpatient psychiatrist. So talk to us about some of these decisions that pull you in multiple different directions, just from a practical standpoint, so we can really just see that in action.
Sure, sure. So, one situation is a scenario where a family brings a loved one who is experiencing a psychiatric emergency, whether they are experiencing thoughts about self-harm, they're experiencing suicidal ideation, and the family is concerned about their loved one. But when the loved one is interviewed by the psychiatrist or by the emergency room staff, they disavow that notion that they're having suicidal thoughts,
Hmm.
while the family is concerned about them that they have verbalized suicidal thoughts. So that creates such pressure. The family wants them hospitalized. The person feels that they're okay to go home and that they're safe. Sometimes the family basically resorts to doing a legal petition to see if they can keep their loved one because they're concerned about their safety. While the person who is experiencing the symptoms says, I'm okay, I should be okay. And that's usually a difficult situation. I talked in the article also about families that feels that their loved one needs to be hospitalized and the hospital evaluates the person and doesn't see that they meet any criteria for hospitalization. A person may have verbalized suicidal thoughts, but now they're doing much, much better. And I reference in the article a piece by a ProPublica, which talks about basically that some patients that needs to be hospitalized were not hospitalized, and that the family wasn't happy about that. The patient may or may not have had bad outcomes, but that hospitals turn away people who are in need of psychiatric hospitalization, while it's usually an evaluation, and whether the person needs psychiatric hospitalization or not is related to laws and regulations. I've also talked about a situation where actually government regulators, the Department of Justice, actually sanctioned a group of hospitals because the government says that they were hospitalizing people that did not need to be hospitalized,
Hmm.
or they were keeping them in the hospital longer than they needed to be. So that's another part of the equation. The family wants you to hospitalize their loved one. The loved one may not want to be hospitalized. You end up kind of caving to some of that pressure and you keep the person in the hospital. And then the government regulators come and say, well, this person didn't need to be in the hospital. They should have been discharged sooner, while you have significant pressure of no place for the person to go, or the family that is saying, no, 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 our loved one is still suicidal, still a danger to themselves. You shouldn't be discharging them. And then the government regulators, the Department of Justice, the payers come and they tell you, no, 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 you should have discharged this person earlier. So, kind of, these are all competing needs. And sometimes the patient's best interest is not the top priority. Sometimes it's insurance payments, sometimes it's family, sometimes it's societal needs. So that's kind of one of the difficult situations that we face on a daily basis.
So when the government comes in and says this patient doesn't need to be hospitalized, on what grounds do they base that decision on?
That's a very good question. So a variety of factors that they consider. Sometimes they just look at the diagnosis of why the person was hospitalized and they say, well, our data says artificial intelligence looked at large data sets and thinks that a good number of days for this a person with this diagnosis is 5 to 7 days. The person has been in the hospital for 10 days. Now, individualized care is very important. So not everybody needs only 5 to 7 days. Some people need 10 days, some people 9 days, some people 14 days. So I think that basically the government and insurers are utilizing AI to basically just do a cookie cutter care, a level of care. Other scenarios is if there's any complaints, if families are complaining, the government comes and basically does a statistical analysis and says, okay, we think 30% of your admissions needed to leave sooner. That's it, pay us back. So we see kind of just a variety of scenarios where the government is just arbitrarily asking or saying that these individuals don't need inpatient psychiatric hospitalization, while actually on the ground, basically, these individuals need significant psychiatric hospitalization. And sometimes that leads to difficult scenarios. But for example, for individuals who have Medicare, a facility may tell a patient, listen, we don't have any criteria for us to keep you in the hospital. An individual has the right to appeal to Medicare and say, I don't want to be discharged from the hospital. I think I need to stay in the hospital. And then the person gets a opportunity for an appeal for Medicare to review the decision to discharge them. So there are some opportunities for individuals where they feel that they're not getting appropriate care or
Mhm.
they're not getting enough care for them to appeal and ask the government to intervene on their behalf.
So it sounds like this issue regarding the competing priorities is multifactorial. What are some reforms or fixes that you would suggest to alleviate some of this pressure on inpatient psychiatrists?
Sure. So, I mean, I think what we need to do is enforce the existing laws that we have. And these laws involve fairness as well as speed and providing appropriate care. We also have to protect patients. I mean, the patient is the number one priority. And that's what's happening is that other competing needs, payers, family, society, other things are trumping the patient needs. We need to also bring in transparency to utilization review because basically insurers as well as the government just have these arbitrary reasons to hospitalize or not hospitalize a person or discharge them. And then there's no transparency. We don't know why the patient was hospitalized, why the patient was discharged. We also need to invest and actually increase the inpatient psychiatric bed capability, as well as what we call post discharge capabilities. So, subacute
Hmm.
units. So, units where the person is not actually per se in a psychiatric inpatient bed, but they're at just a step down level where they could receive some psychiatric care, but they're not at the level of an inpatient psychiatric hospitalization, and also kind of center on focusing on patient dignity and patient rights and ensure that we are basically doing right by our patients, because that's not happening right now in this system where patients are just shuffled very, very quickly and there's other competing needs that are not priorities in our care.
We're talking to Muhamad Ali Rifai, psychiatrist, internist, and addiction medicine specialist. Today's Kevin MD article is The Crisis in Inpatient Psychiatric Care. Muhammad, let's end with some take home messages that you want to leave with the Kevin MD audience.
Sure, sure. I think this tension that we're seeing in competing priorities for inpatient psychiatric care is real. Sometimes we turn people away, and some worry that if we turn people away, we may break the law. If we keep them longer, and you may harm them. If you keep them longer, you may break other laws and invite government enforcement. Sometimes insurance companies will hide the coverage and the reason for hospitalization behind algorithms, and robs patients from care that they need and that they have paid for. So we can replace this tension with a different tension. We can call for accountability, and
Mhm.
we paired that with compassion, transparency, and support for patients, as well as a scientific approach to patient care and inpatient psychiatric care that prioritizes patient needs and dignity to ensure that patients and their families continue to trust the system.
Muhammad, thank you again for sharing your perspective and insight. Thanks for coming back on the show.
My pleasure. Thank you.